Good day, ladies and gentlemen. All sites are now online in a listen-only mode. Please note today's conference may be recorded, and also note there will be a question-and-answer session later on in today's call. At that time, you can press star and 1 on your telephone to ask a question. I'll now turn the program over to our first speaker for today, Maureen Shea. Please go ahead.
Well, good evening, everyone. My name is Maureen Shea, and I'm a marketing manager at iScience. Thank you all for taking time out of your busy schedules to join us tonight. The purpose of tonight's call is to discuss some of the topics that are on the minds of surgeons considering canaloplasty, as well as those of you that are new to the procedure. Some of these topics include the validity of the procedure itself, how to select the right patients for canaloplasty, navigating through the canaloplasty learning curve, and just in general advice to new canaloplasty surgeons. As many of you probably know, canaloplasty is a rapidly growing procedure to treat glaucoma. Over 20,000 procedures have been performed to date, and we are on pace to become the second most common surgical procedure by the end of 2012. To lead this discussion tonight, we are happy to have with us two experienced canaloplasty physicians. Dr. David Richardson is a general ophthalmologist from Pasadena, California, and Dr. Shannon Smith is a glaucoma surgeon from Nacogdoches, Texas. We definitely will be taking questions at the end, but ask you to hold them until the general discussion is complete. At this time, I would like to turn it over to Dr. Richardson. And Dr. Richardson, just take a few moments to walk through your initial experience with canaloplasty, why it became part of your practice, and your overall experience with it thus far.
Sure. I can actually say that my patients drove me to perform canaloplasty. I was actually not performing incisional-based glaucoma surgery in my private practice here in Los Angeles. Essentially, based on my experience in residency with the hassle of trabs and tubes, as well as the complications associated with them, whether in my hands or the attending's hands. I made the decision that I was not going to perform glaucoma-based, incisional-based glaucoma surgery. Now, being in Los Angeles, I had some luxury there because I'm surrounded by academic centers. There are plenty of every subspecialty that you can think of. So, pretty much, if you decide not to do a surgery, you're not going to be limiting the options to your patients. So I was largely performing ALT and treating with drops. And where patients needed additional surgery, I would send them on usually to the Doheny Eye Institute, where there are excellent surgeons there, Brian Francis, Vic Chopra. And it was only something that I did maybe a half a dozen times a year, a dozen at the most. So I didn't really feel that there was a big need in my practice for me to perform glaucoma surgery, other than laser-based. But I was developing a cachet of patients who had been with me for a decade, more or less. And when it came time for them to consider glaucoma surgery because their drops simply weren't working, they wanted me to do their surgery. And I didn't have anything really that I could offer them that I was comfortable with doing. And I certainly was not interested in relearning how to perform trabs and tubes 10, 12 years into my practice. So I had one patient in particular, just a delightful woman in her late 80s, who was taking 10 drops a day, including it was 10 individual drops, including pilocarpine, and she was progressing. So I sent her, as I did most of my other patients at that level, though I don't really have that many patients who are on pilocarpine. That was kind of a holdover from the her prior physician. In any case, she went to the local glaucomatologist who told her, "You need a trab," explained it, and she came back to my office, and I said, "Well, how did it go?" And she said, "Well, I need a trab." "Okay, so when are you going to schedule it?" And she told me, "I'm not." I said, "Well, you understand, you're losing vision." I showed her the visual fields, To which she replied, well, I guess I'm going to slowly lose vision because I'm not having that surgery. I spent some time with her explaining, that the surgeon that she was seeing was an excellent surgeon. She said, yes, I know, but I've read about the complications associated with the bleb. I'm not interested, and if I was going to have any kind of surgery with those kind of risks, I'd want you to do it. Because we had a relationship, as I know, all of you on this call have patients like that. They have a relationship with you. You're their doctor. They want you to do the surgery. So I told her, I said, well, there is a surgery that I've heard about. I've been told that it's safer than trabeculectomy. I don't know if it works as well, but if we could get you off some of these drops and get your pressure down, that'd be a big improvement. She asked me how many I'd done, and I said, I've not done any before. You would be my first. And she said, well, if my only other option is the trab or slowly losing vision with drops, then I'd like you to do my surgery. So I went ahead with surgery on her, and pretty much got all of my complications out of the way on my first case. Large hyphema, induced astigmatism, Decime's detachment. Discovered that what most surgeons fear about canaloplasty, the rupturing the window or not finding the canal, just wasn't an issue for me. It was the experience post-op. But the amazing thing is that having gone from 0 incisional-based surgeries, the things that she and I experienced early on in surgery all resolved with very little effort, and she ended up with better vision than she originally had because the ocular surface was so much better. The pressure was down at 10 off all drops, from 10 drops to 0 drops, pressure of 10, and she was ecstatic. The eye felt better, she was off the drops, good vision, and despite us experiencing a number of early complications, she wanted to know, when can I have my second eye done? And to me, this was such an eye-opening experience, because I don't have any patients who have a trab in one eye who are asking, when can I have this surgery done in the other eye? That experience is something that, complications aside, because actually as you get through the learning curve, the complication rate significantly decreases, and your comfort with things that can happen increases, because this is pretty much as close to a no-harm, no-foul glaucoma surgery as you're going to get. The things that can happen early on after surgery generally resolve on their own. You just don't get flat anterior chambers. The things that you really worry about, long-standing hypotony and hypotony maculopathy, just don't happen. And so you get comfortable as a surgeon offering this to your patients, knowing that they're likely going to have improved pressure, benefit from decreased drops, and like your cataract surgery patients, they're going to want to know, when can I have my second eye done? So that really kick-started my sense of comfort with this procedure and summarizes why I went from doing 0 incisional glaucoma surgeries to right around 70, 80 my first year, just from the pent-up demand that I had in my practice. And we can get into how is it possible that a practice that was only generating half a dozen or so trabs or tubes a year, actually had the demand for 10 times that amount of incisional glaucoma surgery. And really, this is something that most of you who have mature general ophthalmology practices, and by mature, I mean 10 years out or so, your practice has enough glaucoma with patients who would actually be interested in and ask for an alternative to their drops if they thought that one was available and safe. So
Okay, great. Dr. Smith, your experience is obviously a bit different because you're a glaucoma surgeon. Can you talk about your initial experience with canaloplasty and why it is currently a part of your practice?
Yes, and the first thing that I would say is that everything that Dr. Richardson said is true. And the fact that canaloplasty, really, to me, the validity of the procedure is exactly what he said. The fact that with canaloplasty, you may have some bumps early on in the early postoperative period, but the fact that it's not a bleb-dependent surgery like trab or tube shunt are, and it is an IOP lowering procedure without bleb dependence, that's what really sells the procedure's validity for me. And when I was doing my glaucoma fellowship, probably more than 20 years ago, with John Lynn, Ron Feldman, and Rich Starita, that was at about the time that viscocanalostomy came into vogue, and it was enticing because it was non-penetrating. But the dissection was long, arduous, time-consuming, and those surgical workshops really left me with the impression that Schlemm's canal was very difficult to access. So after gravitating into private practice for the last 20 years in a small community with a large draw area where we really live and die by word of mouth, I stayed away from less traditional surgeries. I'm a 20-year veteran of trab and tube shunt, and those are dependable surgeries, but with significant long-term morbidity due to the fact that they are bleb dependent. And, you know, after I was convinced by even now the U.S. data on canaloplasty, I made the decision to take that plunge and experience the learning curve and really commit to adopting the procedure. And, you know, my perceptions that it was going to be inappropriately time-consuming and inappropriately arduous were really different from the reality. When I made the commitment to adopt this and get through the learning curve, I heavily involved the iScience training team. They're excellent surgical mentors, and a lot of us out there in private practice hesitate on adopting newer procedures specifically because we have no surgical mentor on site, and we don't feel ethically comfortable sometimes adopting new things when that's the case. But the iScience training team are a very diverse and a big team of just superb trainers, and they come in and actually mentor you in the operating room. And if you commit to that learning curve, you do get comfortable with the procedure and the fact that it is, I want to use the term lightly, no harm, no foul, compared to the long-term morbidity that you face with the penetrating procedures. So I did make the commitment and get through the learning curve, and I am really thrilled to have done that because my perceptions of the difficulties and the potential inappropriateness of the time involved in the OR, they were very different from reality. And this is a compelling procedure to do early for patients with even earlier moderate glaucoma, especially patients who run significantly high pressure. It's far more comfortable to subject the patient to this procedure than the long-term morbidity associated with the penetrating procedure. And that may be why Dr. Richardson was wise to only do a few penetrating procedures if that was not a common procedure for him. But obviously he's very comfortable performing canaloplasty because it is so much less risk and does lower pressure significantly and it's just much more aesthetic to offer this procedure to patients prior to going for the big guns.
Okay, great. So regarding the learning curve, I think you both touched on it to some extent. Dr. Richardson, can you give your advice on how do you get up the learning curve? You mentioned that you did 60 or 70 procedures in your first year, so you obviously got up it quickly. Can you talk about the steps and the keys to getting through that initial learning curve?
Yeah, the main thing is you want to get as many patients scheduled as close together as possible. It's not that different from just about any other learning curve that we try to get up. Is having multiple iterations close together just makes it so that you do not have to relearn the steps each time you go back to the OR. I mean, this is a procedure that for most of us, these steps are unusual, especially if your primary surgery is cataract surgery. There's really nothing in common with what you do during canaloplasty. So it's very important to get familiar with these steps to the point that the steps themselves become automatic, and you can then focus on the actual skill of what's involved in the surgery. And one way to get up this curve quickly, besides finding the patients to schedule 2 or 3 every week or 2 for the first half dozen would be ideal, is to actually do what good athletes do, and that is before any kind of event, they go over in their mind what they're going to be doing. So I highly encourage anyone on this list who is starting to do canaloplasty or thinking about it or already in the early learning curve, read over the information that iScience provides. It's very good basic information over the steps. Memorize the steps. Take the time before surgery to actually memorize what the steps are. Go through them in your mind. Watch some YouTube videos. There's YouTube videos. There's iTube videos. I mean, these are the time that you invest before surgery, getting familiar with it, is going to make you so much more comfortable when you're in surgery. And then, of course, iScience, as Dr. Smith has already indicated, provides such excellent support. There is no other surgical device company out there that I can think of that provides anywhere near the support that iScience does. So whereas most new surgeries, you'll be fortunate if you get a half an hour wet lab on a pig eye at one of the major meetings and then just be let go with some kind of fake certificate that's been printed up for your liability insurance. I mean, iScience sends somebody out to your OR with human cadaver eyes, sits down for an hour and a half, 2 hours, goes over the procedure till you're comfortable with the anatomy on the cadaver eye, and then is there with you for the first half dozen or so actual surgeries with somebody guiding you along. On top of that, iScience has a group of faculty members that are other canaloplasty surgeons who are available by email or phone to help you along with any questions that you might have in terms of how to do things or in terms of actual issues that you might be having with the actual canaloplasty patients pre or post-op. So the support is there, and the key is really for you to prepare and then to schedule these patients as close together as is reasonably possible. Dr. Smith?
I agree. Multiple cases on the same surgical day and on consecutive weeks, and I tend to book those at the end of the surgical day when I'm less distracted and I can slow down mentally and just enjoy that dissection with the mentor being present at first. It's really very helpful to do that, and reviewing videos reading what iScience provides again. It's all valuable information and will very well prepare you to get into that learning curve. But if you just book a few cases occasionally, the learning curve will never happen, just like with any other procedure. You've got to go for repetition, and again, I typically put those at the end of the day so that I can relax and get into that dissection. Really, after doing probably a learning curve of 10 or 20, you'll be surprised at how efficiently you can do the surgery. 15 to 20 minutes is pretty common.
Okay, great. Let's talk about the right canaloplasty patient. Dr. Smith, can you just continue on and talk about who you believe is the right patient for canaloplasty, and then Dr. Richardson discuss that as well, and if that ideal patient has changed at all the more you've gotten comfortable with the procedure?
Yeah, the classic criteria for a successful canaloplasty, first and foremost, the angle must be open. You don't want to do canaloplasty with a retention suture that stretches inward, trabecular meshwork on an eye that has a critically narrow angle. You want that angle to be open so that you don't produce PAS, and you want to be sure that your gonio exam demonstrates an open angle pre-op, and you want to be comfortable doing a gonio exam post-op if you're having any issues with pressure spikes, etc. There is a relative contraindication in patients who have had prior ALT, possibly less so with SLT, and I'd be interested in knowing what the opinion on that is from Dr. Richardson. But I have had the experience that in patients with prior ALT, it's fairly common to have the catheter and or the Prolene suture prolapse through the meshwork into the anterior chamber, presumably because meshwork is a little more brittle in those patients. So I think your highest success rate for no prolapse of catheter or suture through the meshwork into the chamber would be in patients who have had no prior ALT and possibly no prior SLT, but that's a softer contraindication. Patients who are relatively naive to a very long history of IOP-lowering meds and probably naive to a very, very long history of advanced glaucoma will be more successful with canaloplasty because that network from Schlemm's canal through the aqueous collector channels in the sclera is more amenable to being opened up and functioning when you've not bypassed it for decades with IOP-lowering meds or atrophied it with untreated recalcitrant glaucoma for decades. There's theory on that, and I think that's probably true. So patients with early to moderate glaucoma with certainly open angles who perhaps have not been subjected to decades of treatment or advanced damage that goes unchecked, those are your best candidates. But I'd submit to you that black patients who have a notoriously just dismally high failure rate with penetrating surgery, all of us have the occasional black patient who walks into the office in middle age, undiagnosed, with open angles and pressures of 50. I think those patients, even if damage is advanced at that point, actually deserve a trial with canaloplasty prior to penetrating surgery. I'm feeling more and more strongly about that after having done canaloplasties for about a year now.
Okay, Dr. Richardson, can you talk about your patient selection paradigm and given that you're a cataract surgeon, how phaco-canaloplasty fits in with your practice?
Sure, sure. I just want to comment on a couple of the things that Dr. Smith mentioned. I absolutely agree with her that offering canaloplasty earlier on makes so much sense. And I now have actually stopped recommending argon laser trabeculoplasty or selective laser trabeculoplasty.
Me too.
So, well, I'm glad to hear that I'm not I'm not unique there. But I just feel that, and clearly you feel this way also, that if a patient's going to need to get a significant reduction in the pressure, and they may need incisional surgery down the line, the last thing I want to do is somehow focally destroy their trabecular meshwork and decrease the likelihood of a truly successful treatment for their glaucoma down the line. So I just do not, I don't offer it myself anymore. I still have the discussion that it's an option, but I tell my patients I don't perform it anymore because I don't want to do something that is then going to decrease your chance of successful treatment of your glaucoma later on when you really need it. As far as the argon laser trabeculoplasty making it more difficult to catheterize, I do think that that's true, especially in those cases where someone has had a more traditional, older style trabeculoplasty. You know these when you gonio and you see this kind of sawtooth PAS to the trabecular meshwork, and there's no question that your gonioscopic skills need to improve and will improve because having that good quality gonioscopic exam before surgery is going to enable you to better stratify your patients in terms of how likely they are to achieve successful cannulization. And I'll tell my patients, if I see that sawtooth, I'll let them know that there's a fair chance that I may not be able to fully catheterize the canal. But even if the stent cannot be placed, that's not necessarily a failure. I have a number of patients now that, for whatever reason, generally ALT, they have one eye that I was able to achieve full catheterization, and the other eye I was not. And in these patients, the difference between their pressure runs about 3 millimeters of mercury. So in each of these patients' cases, the target pressure was in the mid-teens, and that's where they are without the stent. And the eye with the stent is in the low teens, which is wonderful. But if you're going to need to get a pressure around 10 or 12, and you see somebody with sawtooth PAS from prior ALT, that patient does have a high risk that they're not going to achieve the pressure you need without drops. Now, if they can tolerate drops and that's acceptable to continue with drops, I would just have that discussion with the patient. But what you're going to find is that there's the ideal patient for canaloplasty, and then there's a range of patients who can still be very good candidates for canaloplasty, but you may have to manage the expectations. And in my practice, the patients that I'm finding are the most interested and, in my view, the best candidates for canaloplasty are those patients who have a cataract, have glaucoma, they're on multiple medications. So I'm worried about the possibility that they're going to have a pressure spike after surgery. I'm also quite confident that cataract surgery alone is not going to lower their pressure enough that they're going to be off of their medications. If they're on one medication and they're well controlled and they have mild to moderate glaucoma, you may be able to get them off the drop after cataract surgery. And I know everybody right now is excited about cataract surgery as a treatment for glaucoma. And for a small subset of patients, it is a possible solution. But if your patient's on 2 or more medications, and when I say 2, honestly, we're talking 3 because most of us who have patients on 2 or more medications, one of those medications is a combination agent. Those patients are not getting off all of their drops with cataract surgery alone. Those patients are ideal canaloplasty candidates because, in general, they know they're going to surgery for cataract surgery. They're already going to be there. And if you as a surgeon have something to offer them that can not only provide some safety against the pressure spike that they might have, that you might not have a whole lot in your armamentarium to treat because they're already on maximum tolerated medical therapy, and you can offer the possibility of getting them off of these drops, then this is going to be a situation where you are going to have truly, truly thankful patients. These drops are expensive, they worsen ocular surface disease, and Phaco-Canaloplasty has a rate of success, and by success I'm talking controlling the pressure and being off all drops of between 80 and 90%. And so you can really recommend this surgery with confidence, and your patients will be thanking you for it.
Okay. Dr. Smith, can you talk a little bit about the post-op care of canaloplasty patients and what the treatment regimen is for them post-surgery?
Yes. The most important thing that I'm learning to talk about with canaloplasty, Dr. Richardson touched on this a moment ago. Day one, it's fairly common, and I'm not sure exactly what the mechanism of this is, but it's common to have at least a circulating, if not additionally layered hyphema on day one, and this will tend to blur vision. My TRAB patients really typically have no blurred vision on day one post-op, but they will have blurred vision predictably with canaloplasty, but it's very short-lived. And I think that the mechanism, presumably, is that you force aqueous through the system when you do the canaloplasty and stretch the Schlemm's canal, and the pressure in the eye lowers, sometimes dramatically, and I believe that you get a reflux of blood through Schlemm's into the chamber. So it's not that there's something bleeding, it's that you have a reflux of blood through the system. And it's very predictable to have that hyphema on day one. But again, typically it resolves within the first few days to the first week or so. But it does blur vision right after the surgery. And that pressure lowering also, Dr. Richardson touched on, induced astigmatism. I think that's fairly common because you've got a retention suture in the canal, tensioning the angle, and in the scenario of some hypotony, you may also have that astigmatism and blurred vision. Also, the limbal closure is the most common closure with canaloplasty. You can do canaloplasty with a farnesyl incision, but I typically do the limbal incision that's usually recommended. The limbal vicryl that you use there, when it starts to dissolve, it can commonly cause some foreign body sensation. And if tears don't resolve that, sometimes I'll put a bandage contact on the eye until the suture dissolves. But other than that, I have had a couple of cases of hypotony with dramatic lowering of pressure in 2 really young high myopes. One of those did get very short-lived choroidal effusion for less than a week. So you'll see that occasionally, but again, all of this stuff is early, short-lived, compared to the very serious long-term risk that you face with blebs that have unpredictable morphology and leakage and infection risk long-term.
Hey, Dr. Richardson, do you want to touch on that relative to cataract patients or just how your treatment post-op paradigm is?
Yeah, I agree. I think that the most important thing you're going to have to tell your patients is just that there will be some blurring beforehand. And once you let them know why that is, not only do they understand it, but I actually have patients now that are upset if their vision is absolutely perfect the first day after surgery because they're worried that the surgery didn't work. Where's the blood? You told me there was going to be reflux. And there have been 2 European studies that have shown a correlation with successful IOP lowering from canaloplasty being associated with a hyphema. So you really do want to see hyphema. And let's see, I have, for this call, I had my optometrist go through our database, and we looked at the first 82 eyes who are now out 250 days or more. And of those 82 eyes, I had a frank hyphema, which is more than a millimeter of hyphema in 48 of the 82 eyes.
Right.
Most of the others had some hyphema, but it was less than 1 millimeter or a microhyphema. And these, on average, resolve usually in about, as Dr. Smith mentioned, a few days to a week or so. The absolute longest that I have here was I had one patient who had about a 3 millimeter hyphema, and it lasted for over a month. But that was a really, really unusual case, and there were other extenuating circumstances. But both in my experience as well as the published literature suggests that on average you're looking at about six days.
Okay. So I just have one more question. We definitely want to leave time for audience questions. So if you have them, start thinking about them now. Just in general, Dr. Smith, what is your advice to surgeons considering or just starting canaloplasty? If you have any parting words.
I think the best advice is again to read the data, read the eye science provided information. Be prepared to commit to a learning curve. For me, that was the single, I think, most important thing was just that emotional commitment to book those cases and keep your repetition up to a level that gets you very confident with the dissection of the procedure quickly. That may be the single most important thing. I also wanted to touch on pressure spikes and pressure variations. Robert Stegman talks about a high-pressure phase after canaloplasty. I think some patients are prone to that, some are not, but the steroids that we use are a big factor in that. And with these angle surgeries that are non-penetrating, it may be really important not to use. I quickly gravitated away from Durezol and toward Lotemax, a lower dose steroid for these angle surgeries because they will tend to quickly sometimes have a significant pressure spike. And there is a high pressure phase that's talked about that can be real variable between patients. So you want to be sure that you're watching the steroids after the surgery. Sorry, I just wanted to interject that for the early postoperative discussion. But for me, learning curve was absolutely key. Committing to the learning curve with lots of repetition was key for me personally in adopting the procedure.
Okay. Dr. Richardson, do you have any parting advice?
No, I'd second all of that.
Okay, great. Well, I think we will open it up for questions if we could bring the moderator back in.
Certainly. At this time, if you would like to ask a question, please press star and then 1 on your telephone. If you need to withdraw your question at any time for any reason, you can press the pound key. Once again, star and 1 on your phone to ask a question. And it looks like our first comes from Ray Hernandez out of Texas. Please go ahead.
Hi there, Ray Hernandez here. I just had a question for both doctors regarding instrumentation. If in the course of doing all these procedures, if they have modified or changed the instruments that are used in the typical practice by eye science.
Yeah, there are a variety of instruments that are used for each of the steps. I'm a veteran trab surgeon, so I'm almost embarrassed to admit this, but I use a 15-degree blade to dissect the superficial flap, and I did go to the round, there is a round greasehaber blade that's a spatulated blade that's very elegant for dissecting the deep flap, but I initiate that with a 15 degree because I like to see the fibers as I cut them and know exactly how deep I am. With the dissection of the deep flap, it's very important for your success at opening the canal to be very, very deep, just a couple of scleral fibers above choroid. And the trainers were very instrumental in demonstrating the different instruments to me. There are some various things that you can use to cut off the deep flap. There is a spatulated protected diamond scissor blade that Howard Barnaby, I think, designed that helps you to dissect forward as you're creating the Decimase window in an effort not to perforate it. But the trainers are your best resource on the instruments. They'll show you a variety of instruments as you're learning the procedure, and you can decide which ones you want to commit to.
It's really quite nice to see the number of instruments that are now available, because when I first started performing canaloplasty, there really wasn't much available. And Doug Mastel has done a great job in working with canaloplasty surgeons to design a couple of very well-engineered, as are most of his instruments. I actually have moved in typical, I suppose, cataract surgeon fashion to a diamond blade. And I used Doug Mastel's PhD 2 blade. Had you asked me before starting canaloplasty whether I would ever consider investing that much in a blade, I would have laughed you off as being ridiculous. But once you get comfortable with the surgery, and you understand that, as Dr. Smith mentioned, seeing the fibers being cut is so critically important that my preference for that is to use a diamond blade, because you can actually see the fibers being cut without putting pressure on the fibers, at least with the Mastel blades. They're so delicate and so sharp. It's just truly elegant. But I think that she's absolutely, I think that she's absolutely right in stating that the support that you get from the clinical specialist is just wonderful. And they're going to help you find the instrumentation that works best for you, what you're comfortable with. And, whether it's a diamond blade or a 15 in a greasehaber, it's really, the surgeon's skill drives the surgery, and the instrumentation is really secondary.
Do you have any other questions queued up at this point?
Yes, once again, it is star M1 to ask a question. The next question comes from Patrick Way from California. Please go ahead.
Yes, I have a kind of unconventional question. I was in a conversation with a glaucoma specialist here locally, and that specialist has a very strong feeling about a general ophthalmologist doing canaloplasty, and that specialist put in a way such that if there should be a complication, it almost should be a malpractice case, because the glaucoma specialist saying that for a general ophthalmologist to be able to identify the traumatic mesh organ Schlem canal is almost impossible or very difficult. So that specialist saying that this kind of position should be reserved for the glaucoma specialist, but not to a general ophthalmologist. And I'd like to know what your opinion is.
Dr. Smith.
I'm glad Dr. Richardson is laughing, because that's ridiculous.
Uh-huh.
And, all of us start somewhere when we're in training. Glaucoma is so incredibly common, and every one of us is crippled if we're a general ophthalmologist who doesn't address glaucoma procedures. And Dr. Richardson was just superb to recognize the morbidity and risk associated with the penetrating procedures. So save those for maybe the fellowship-trained glaucoma person if you haven't done a lot of them. But canaloplasty is within the reach of everyone. And yes, you do need to dissect sclera, but just like with any other procedure, the more you do that, the better you get at it. And, there's nothing magic about glaucoma fellowship training except for the fact that we get the train wrecks, if you will, who really need end-of-the-line procedures. That's what's beautiful about canaloplasty. It's an early procedure, and it should be a procedure for everyone.
Yeah, okay, glad to hear that. Because I'm also afraid that she feels so strongly that anyway. So I'm glad to hear from from another glaucoma specialist who feels that there's something that a general ophthalmologist can definitely perform. And the other question I have, if you don't mind, I don't know if there's any other questions, but what about for patients who are actually already in the mid-range in terms of the pressure, but they have visual field, they are defect within the fixation, and then they need to have a lower. Are they good candidate for canaloplasty? Are they able to lower the pressure to around 10 or so?
I believe that they are a good candidate because the dilemma we face with, quote, normal pressure glaucoma, end quote, is that we don't know it to be normal pressure. We don't know what the patient's pressures are in the middle of the night, and we don't know what their pressure variations are. And if they have classic glaucomatous optic nerve cupping with corresponding visual field defects, you can imagine a procedure that opens up Schlemm's canal and the network of aqueous collector vessels should stabilize pressure similarly to a penetrating surgery. And if that patient is naive to penetrating surgeries and ALT especially, and probably SLT, I think they deserve a chance at canaloplasty. And maybe I shouldn't have even said penetrating surgeries. I've done a few canaloplasties on patients who have had as many as 2 trabs failed, but the ostomies were well anterior to the meshwork, and they've done beautifully with canaloplasty and suturing the canal. They did not have prior ALT or SLT, and these were both young black men who classically failed penetrating surgery quickly and aggressively and have done beautifully with canaloplasty.
Thank you.
Another indication of just how valuable a good gonioscopic exam can be.
Right.
We think that somebody who is status post penetrating surgery is not a candidate for canaloplasty, and it's, first of all, it's not the case in those cases where the trabeculectomy site is anterior, as Dr. Smith said, but secondarily, it is possible to perform canaloplasty adjacent to a prior trap site.
Right.
And it's technically challenging. I wouldn't recommend it in your first dozen or so, but it is possible. So this is a surgery that we're discovering has broader and broader reach. And what you'll find on the other extreme, so what was mentioned was fixation splitting. Well, actually, I've spoken to a number of glaucomatologists who feel that canaloplasty is the ideal surgery for fixation splitting because the worry about fixation splitting, and I'm going to defer to Dr. Smith if I get this wrong, is my understanding is that when you split fixation, you're worried that if there's a significant pressure spike after surgery, you could actually completely lose that. Whereas with canaloplasty, because you're unlikely to get huge pressure spikes after surgery, that there may be it may be a safer option for even those in-stage patients. And it's certainly an option that leaves open additional options down the line, whereas you cannot go the other way around in most patients, with the exceptions that we just stated. In general, canaloplasty is a better first surgery rather than second or third.
Correct. And now I want to say something on pressure spikes, though. My personal incidence of pressure spikes, because I'm now, a 20-plus year veteran of TRABs, my personal incidence of pressure spikes is higher post-canaloplasty, but they tend to occur early. So I would have caution in patients with split fixation. The other issue is valuable real estate of the conj and the sclera. You can do canaloplasty temporally, but you have to be very careful to do a tight closure. And the general rule for canaloplasty is that it's desirable to have a tight closure of that superficial flap anyway, but particularly if you need to move temporally to save valuable real estate superiorly for penetrating procedures in a patient with pretty advanced glaucoma, you can go temporally, but with a very tight superficial flap closure to avoid bleb formation in the interpalpebral fissure. And there is some incidence of bleb formation with canaloplasty. Classically, it resolves with a short period of time. But in my series, I have had one woman who got such a significant bleb, and she had 5 sutures in her superficial flap, but a very significant bleb with bleb runaround into the interpalpebral fissures, and I had to revise that surgically. So sometimes you will get a bleb. You can place the canaloplasty temporally, caution for tight closure, and I would have some precaution with patients with split fixation because of the tendency for a pressure spike, especially with a stronger steroid use post-op. I've gone strictly to using Lotamax with all canaloplasties and trying to get patients off of it quickly.
I've also moved in that direction. There's clearly a pressure elevation that can occur between weeks, it seems, 2 and 5
right.
in my patient population. On the other extreme are the patients that I would never have thought to even offer canaloplasty to, but in my practice now ask me whether they're candidates for it. And those are the patients that are, in my mind, controlled. They're not progressing via
right.
HD SCOTI or visual field, but they're on multiple drops, and they're miserable.
Exactly.
They want a safer alternative that will get them off drops. And unfortunately, the laser trabeculoplasty is not going to get them off drops if they're on more than one. And the other penetrating procedures generally don't help out in terms of the ocular surface and are really too risky for most of us to feel comfortable offering
exactly.
in a patient that's controlled. So.
Yeah, there's a huge population of patients out there who are overburdened with drops, both financially and physical symptom-wise, corneal surface disease-wise, and canaloplasty is just a superb option for those people.
Yeah. My practice is really a statement to that fact because I was only sending out a half a dozen or so patients out for incisional surgery a year, and yet somehow my practice generated over 60, almost 80 patients that first year who I performed canaloplasty on. And for those of you who think perhaps I'm a great salesman, I actually have a horrible conversion rate to premium IOLs. I mean, it's about 7%.
Yeah, that is a testament. That's a testament to the kindness of the procedure compared to the penetrating procedures. Even the best trab surgeons are seduced by canaloplasty because it's so much kinder to the eye.
Mm-hmm.
That's the reason that you get comfortable with that procedure and you suddenly have an influx, a wealth of patients who are excellent candidates for that.
Absolutely.
Thank you.
Do we have any other questions lined up?
It looks like we have no further questions.
Okay. Well, that wraps up the call. Before we leave, I wanted to just make a couple of announcements. One, iScience is going to be holding a didactic at the upcoming ASCRS on Friday, April 20th. So if you're attending the the conference. Dr. Richardson will be one of our presenters. We will also have Dr. Mahmoud Kiami from the Dean McGee Eye Institute, and then Dr. Michael Morgan from the Ashner Clinic Foundation. We're going to be hitting on some of the topics we did tonight, but in a bit more depth, as well as going through the procedure itself and the clinical data. So that event will be held at 6 p.m. in the Hilton Chicago in the private dining room 2. And if you're interested in learning more about canaloplasty, I would encourage you to visit our website at www.canaloplasty.com. We do have presentations from both Dr. Richardson and Dr. Smith in our video section, and we have several videos on advice from other surgeons on several of the topics we talked about tonight. Or you can always contact your local regional business manager. I wanted to just say a special thank you to Dr. Smith and Dr. Richardson for taking the time tonight to present to us, and to all of you for taking time out of your schedules to attend the call. Thank you very much.
Thank you for having us.